Is there a motion to approve or amend the agenda?
So moved.
Is there a second?
I'll second it.
Okay, please cast your votes. Motion passes. This meeting will be divided into 3 sections. First, a work session to hear and discuss presentations that do not require a council vote. Second, be followed by a closed session. And then finally, the city council business meeting will begin at 6:30. First up, we have reports, the Map to Health report from the Blue Ridge Health District.
Good evening, and thank you for the opportunity for us to speak and provide an update on the Map to Health Community Health Needs Assessment. My name is Ryan McKay. I'm the director of the Blue Ridge Health District. I will spend very little time talking to you as I want to give Jen Fleischer as much opportunity to speak. She's the expert on this process. She's been in it since 2022. But I will say that historically, the Blue Ridge Health District has been doing this process since 2009, working with Sentara and UVA Health to really identify health problems throughout our district, including the city of Charlottesville, but really with the intent of identifying upstream solutions and systems to address root causes of health problems. Over the years, we've identified concerns around tobacco use, pregnancy outcomes, infant mortality as it relates to sleep. And while many of our partners provide direct services to the community, internally we have really taken the lead on a few key things. We use this to hire a tobacco cessation specialist who worked with community partners, schools, and other organizations to implement new policies and education around smoking. We've hired a maternal child health coordinator in the past to really convene an improving pregnancy outcome work group, which has since transferred to another organization, but with the intent of bringing awareness around disparities in health outcomes for mothers in our communities. And then really using the data to identify issues around infant mortality as it relates to sleep. And so from that work in previous years, we identified the need for a safe sleep program where not only did we provide education to new parents about safe sleep practices, but we were also able to secure funding through our own dollars to provide low-income individuals with free cribs through that same process. And so what we've seen over time is that the Map to Health process, mobilizing for action through partnership and planning and partnerships, is that we can really identify root causes, really develop systems and structures to put in place where we are seeing a value on our investments in these really on-the-ground activities and programs, either through hiring the staff with the Blue Ridge Health District, partnering with other organizations, or really implementing upstream programs and initiatives that really address the root causes. We are in the midst of yet another round. It's a 3-year process, and Jen will really explain the nuts and bolts of this in detail. But I just wanted to provide you with some sort of historical context of how long we've been doing this. And I hope Jen would say this too. We are truly one of the leaders in the state within the Virginia Department of Health in this process. We are much more involved as a catalyst and as a leader. And I will say up front that a lot of this in the last few years is all the result of Jen's hard work. So with that, I'll turn it over to our Child CHIP Program Officer, Jen Fleischer, to give you the nuts and bolts and a true update on where we are with our current process. Jen?
Thank you, Ryan. Thank you, counselors, for having us. My role at Blue Ridge Health District, as Ryan mentioned, is to facilitate and initiate this 3-year, it happens every 3 years, but it's an 18-month process every 3 years in partnership with Sentara Martha Jefferson Hospital and UVA Health. And so on other committees that I sit on that some of you attend, you've heard me present some of the nuts and bolts, but just to give you a high-level overview, it's all nonprofit hospitals are required to do a community health needs assessment known as a CHINA. We call it locally a CHA, a community health assessment. That requirement's from the IRS in order to sustain their nonprofit status. So though Sentara is the only nonprofit hospital we have in our district, we have partnered with them, as Ryan said, since 2009 with UVA Health because it's the right thing to do. It allows us to see these community strengths and needs and get the decision-making that's data-driven and address root causes of health inequities. So in the 18 months, we will plan and leverage resources and make implementation initiatives that will be put on the ground by community partners and the 3 health systems once that report is published. So where the CHA is the assessment part, the CHIP is the Community Health Improvement Plan. Because 3-year cycles are pretty short, there's always an overlap with your CHIP happening, your implementation plan, your improvement plan, and your assessment beginning again. And that's part of the design of a MAP. So there's other frameworks to conduct a CHINA or a CHA, but we use this Mobilizing for Action through Planning and Partnerships model, and that's one we've been in place since 2009. So in 2022, that was our last CHA, and we looked at data from local and regional sources. We had 85 agencies connect with us on work groups. Mayor Wade was with us for some of that work. We did a photo voice project with UVA Health. It's a qualitative analysis using photography and local community members, and we published that report in September of 2022. That report had a focus on health disparities, health equity, the social determinants of health, and racism and discrimination, looking at healthy eating and active living, mental health including substance use, health equity and access, and then healthy connections. So what that drilled down to in 2022 was we were going to work in the policy targets of transportation, the healthcare workforce, digital access and skills, and mental and behavioral health. Now, what does a health department have to do with transportation? We obviously are not CAT. We love CAT, but we act as the liaison between community partners to make inroads in transportation that ultimately affect the health of our patients and other community members that we see come through the health district doors. This applies as well to Centera and UVA, and that's how they get involved in these policy targets. So, for example, on the city level, through RTP and through other objectives, CAT has been most involved with the CHIP, as has RTP, as has TJPDC. So these were some of our bullet point goals and objectives for the 2022 CHIP, which will complete at the end of 2025. So the PATH program that some of you know about from TJPDC, and a goal to get UTS, JAUNT, and CAT to share a GPS app were some of the objectives that we continue to work on with them through multiple channels. It's pretty slow, as you know. Transportation isn't the fastest moving mechanism of change, but we're involved, and that's new for us to kind of be at the table at that kind of decision-making level as a voice speaking for health and some of the community partners that we support. And at any point, holler at me to stop and answer questions. So there's other initiatives on this list that you can see that apply to those other policy areas. We continue to work on those, and again, that work cycle will end in 2025. Some that directly relate to us at Blue Ridge are the establishment of the Community Health Worker Collaborative and Network, and we also work very closely with UVA Telemedicine to work on device distribution and a telehealth hub in Southern Albemarle. So other community partners also convene that work. That overlaps with some ongoing PATH program, bus field trips that we've worked on, walkability audits with some of this group and other community partners. And then the Trailblazer program that's working out of the city, we connect with a lot, and the Loop DeVille project. So we are, again, not necessarily, these are not services, we don't build trails, but we are helping to advocate and support with kind of sweat equity to move the needle in some of these areas, again, with that goal of improving health, because we heard from that in the 2022 CHA. This round, we're doing it a little bit differently. MAP Health has gone to MAP 2.0. And so what's different about that is there's a lot more community voice, and there's a steering committee helping Centera, Blue Ridge, and UVA Health to make decisions. So we have convened, our steering committee has right now actually 15 organizations on it, representing kind of a broad swath, as you see in the graphic, from housing to Louisa County Parks and Rec to folks who offer food pantries and food banks. So it really runs the gamut in order to hear from the folks who are supporting the community members that we are trying to work with and elevate during this process. And again, as Ryan said, find those upstream causes. What's also different this year is we did a lot more surveys and a lot more data capture at the front end of this process. So we will publish this report in September. It will be kind of completed for us by the summer and go to press, but you'll see that report in September. And that will be the result of a lot of surveys and data that we captured through 2024. Right now, that steering committee is working on its priorities and what those look like for this CHA and upcoming CHIP. So the other new thing we did this year was to really get locality granularly focused. So we looked at 5 census tracts and 1 in Charlottesville, because again, we're serving the whole district. The census tract in Charlottesville is the Fifeville neighborhood that most triggered the area deprivation index. So it has a 71 percentile ranking on the national percentile for area deprivation index. That is a ranking
Is that a ranking where the higher it is, the
worse?
Yeah.
Yeah, exactly. So that's what I wanted to show you. On this little graphic you see in front of you, the red is worse, right? And that's your most disadvantaged census block. So Fifeville is one of the ones in the city. It is our reddest one in the city, let's say that. And the indicators it's looking at for the ADI, education, employment, do you have a car? Is there a phone at the house? Is there crowding? Is there plumbing? They take all of these indicators by the block and then give this ranking. We are currently not working in the Map to Health in Fifeville because UVA Health is very well situated there and has asked to kind of take the lead. They've already been conducting focus groups and running a mobile unit there. So to avoid engagement fatigue, the Map to Health process is letting UVA continue that work and then hopefully report back to the core group and the steering committee their findings. So right now our census tract focus outside of the city, with Fifeville being covered by UVA. What we did was 267 individual interviews to ask folks what their biggest health problems were, what their biggest obstacles to being healthy were, and what supports they needed to be healthy. We've done these in correlation with community partners. So of those 267 respondents, the vast majority are having an income somewhere $45,000 is kind of or less. And we knew that we were kind of reaching the folks we wanted to hear from, the folks who most are harmed by health inequities and health disparities. We did these interviews at 17 different events and locations, and I personally have done about 200 of those interviews. It was amazing connections with community members, and in the city in particular, just really getting a sense of what does it take to be healthy and not making assumptions about what those answers might make was very informative. We did 4 focus groups. The one you're seeing here was in partnership with the Fountain Fund Charlottesville agency that works with folks in reentry. The other focus groups were older adults with disabilities, an LGBTQ group, and a group of Spanish speakers that work in the community through Latino Health Initiative. So we heard from about 22 folks from there as well. And then we had an online survey that ran for a few months, and we got about 640 responses from that, and a stakeholder survey, so folks who ran organizations and agencies that work with us already, what were they hearing from their clients, patients, and consumers? And here's what we've learned. So the problems in that order: diabetes, blood pressure, mental health, weight problems, and health problems. The biggest obstacles: access to health care, down to lack of exercise, which also pertains to lack of ability for our rural patients to access spaces to exercise. But the biggest support needed is money. So as disappointing as that is really what folks need to be healthy. And so many of the folks we're talking to also needed community support, and in this definition, community support is countering a sense of isolation and encouraging a sense of belonging. So you've definitely heard a lot of stats come out of many agencies right now that are talking about belonging, isolation. This is a key health issue. We heard that as well on the ground. It's interesting to point out that healthy food access is top of the charts again. That has stayed as a priority since 2009. We heard a little bit less of it in the 2022 report. I'm guessing, I don't have the data to prove this, but I would think from my experience in that report, it may be coincided to the COVID funding dropping off, which often provided a lot of food support for both banks and community members individually. And now it's harder again to get healthy food affordably. That was one of the problems. One thing to note about obstacles and access to healthcare, access means I can't get there, I can't afford it when I get there, and I can't get an appointment, so there's not even an option for me to get there at all. So when we're talking about access, it's those three things were at the surface of the conversations we had. Oops. Okay, so from here on in, we're working on this kind of model. It's called targeted universalism, where the steering committee is helping to kind of filter down this graphic you see here to define these priorities. Right now, what you see is kind of our best guess before they make those final decisions. So we think that from what, this previous slide, that the priority areas would be chronic conditions, healthcare access, and social drivers of health. The concept is that we'll focus on populations that experience the most inequities and harm, and in doing so, that will rise up all boats for the whole district to improve their, a healthy weight and food access and activity, the right care at the right time in the right place, and have fewer stressful days with mental health issues and the tools they need to be resilient. So again, this is you're seeing a draft. This is in the works, and the steering committee is working on this language and these priorities now. And then eventually that report gets published. In the fall, we will help to achieve grants for community partners to do implementable, actionable activities and initiatives that address the priorities and the objectives that the steering committee comes up with and finalizes with the core group. And that implementation will start in 26, and then we will track progress in those areas. We are attempting to create a CHIP dashboard to allow the community to hold all the community partners and the 3 core group members accountable for doing the work. So that's the nuts and bolts. Are there questions that I can answer now? Seem clear?
Questions?
Not at this point.
Okay.
Can you explain a little more about where your funding comes from?
For this work,
Yeah.
so Centera and UVA fund it, I was going to say internally. So Centera offers grants for completing this work. It serves them as a requirement. And so they also set aside in their foundation grants to complete this work. We applied for that grant to allow me to facilitate the process. So Blue Ridge used that grant funding. UVA does this out of their Dr. Tracy Downs and Jackie Martin's office, the diversity office, through UVA Health, and they set aside the time to do that. They also provide internal funding for printing of the report. And so VDH and Blue Ridge, we use grants through our population health division to support any other kind of, for example, we did a door-to-door randomized survey in Nelson County as part of this process. We supported that with our staff and our efforts through those population health kind of grant funding. Am I missing anything in the how it's funded? Okay.
Thank you.
I take the money. I don't usually get it, so.
Is there anything in terms of the work that we're doing here that you feel like we especially need to know about or be conscious of? That I see these reports that come out and it clearly reflects a lot of work. Is there anything that you would like to underline for us?
I'm so glad you asked, because I did want to kind of leave you with a bit of action item with this,
Okay.
which is, yes, certainly the work you're doing in bike and pedestrian infrastructure deeply aligns with the previous CHIP, and we're seeing transit and transportation in general is on people's minds. But as we start to develop initiatives, implementation plans, and activities, our ask of you would be stay connected to the CHIP, and for 2025, let us report out again at some point, hey, here's what we want to underline that you can really connect with. Remove obstacles for community partners and organizations and agencies to receive funding either from the city or other grant partners to do the work in tandem with you, and to really amplify the successes of community partners as it goes. So right now, I don't have the underlying thing beyond the transportation and bike ped transit because we haven't quite filtered that down, but I will have that, and I'd love for you to stay connected to that because you can have a real sway in helping keep the voice of the CHA alive and help us stay accountable to that work to really move the needle.
And is your main contact through Deputy City Manager, sorry,
Which one of us are you thinking?
yeah, Ashley?
I think Ashley and Mr. Sanders are our two contacts
Okay.
right now. Yeah, so we can kind of stay in touch that way. And then you'll see easily broadly on the Blue Ridge site as we're the kind of host, more information about staying in touch with that chip as it gets developed.
And I'm sorry, so Ms. Marshall Reynolds would be your main person that you work with? Or-
This is my first time working for city, so I know that Ryan is mostly spoken with Mr. Sanders.
Okay.
And so, but anyone that is the best contact to moving forward, we're happy to stay in touch with.
Okay.
Yeah.
I don't know if you had anything to offer on that. No.
I mean, Ashley is tracking everything, and wherever we need to pull additional staff in, we've done that.
Okay.
Make sure we get the information.
Okay.
Is basically, you touched on a little bit, basically is what you're seeing, the biggest barrier is people don't have health insurance and have stagnant wages with rising costs of living.
The latter. Almost everyone we interviewed had Medicaid, so health insurance was happening. Almost all of them had gotten back on Medicaid through assistance through the network of partners they work with. What they didn't have was time to take care of their health. They didn't have enough money to make the pieces of connections to health happen. I don't have enough money to take care. I have a car. I don't have enough money to take care of the car to get to the appointment. There was a big reliance on CAT. Particularly, we spent time interviewing a lot of folks who were unhoused and during the POCM shelters that were stood up for the holidays. The bus transit is definitely their way to and from medical appointments, but reaching out beyond that loop, it was much harder to get appointments, to have the time to make those appointments, to have the wraparound services to get to the appointment on time and back on time, particularly for older adults and those with mobility issues. Those two groups of folks have the hardest time accessing that connected services piece or having the funds to make those connected services happen.
But PATH is kind of,
PATH is working on that.
and
yeah.
now PATH didn't exist when you started these surveys, right?
PATH became a thing of CHIP 2025 and has been working with us as we started these surveys. Very few people have used PATH still. It's still getting its legs.
Yeah.
That idea is great, but even PATH has a hard time connecting the dots of getting those folks rides. But also, we heard a lot about all of my money is going to rent, plus we're getting evicted, or I need more support. A lot of the conversations were about food. I can't afford food anymore, so we're making ends meet this other way, and it's just the mental load. It's too much to manage, and it's what they can get rid of. Oh, I don't need to go to that appointment. Almost no one had a dentist. Oh, I don't need to go to that dentist appointment. Was happening in the folks we interviewed.
Did it come up as a frequent barrier that people had trouble, particularly for preventative care, finding a provider who would accept Medicaid, or was that not a significant barrier for the region?
I'm glad you asked that. One of our projects from 2025 was particularly around dentists accepting Medicaid. We knew we had proportionally the right amount of dentists in Charlottesville, but they weren't taking patients. What good does that do if the proportion's good? So we worked with DMAS to improve the amount, and to incentivize more dentists to take Medicaid. And we didn't get very far on that. What we found in the doctor side of things it doesn't seem that, the folks I spoke with did not have a problem getting their insurance accepted, or they just couldn't get an appointment at all. So it wasn't so much a part of the conversation where they certainly talked about the gaps in what Medicaid would cover and what they needed for specialty care, particularly in our rural localities. But it didn't come up so much as, I can't get an appointment because they don't take Medicaid. I don't know that there was a lot of research outside of the providers that they've already seen who were Medicaid accepting providers to find out other options. There was also lack of kind of that brochureware knowledge, like there is a free clinic or there is an FQHC nearby, have you tried those options? Oh, I don't know what that is, I'm not sure where that is. So there seemed to be also this gap that needed filling of spreading the word about what other options might be at play.
Then finally, did you get feedback on the mental health side about, did people have thoughts or issues that frequently came up in terms of how accessible Region 10 was in terms of their capacity and their assessment of the quality of care they'd be able to receive in terms of mental health needs?
Yeah, definitely. Certainly for rural localities, it was suffering, particularly for youth in the folks we interviewed. The question we asked for mental health was, how many days in the last 30 days have you suffered from chronic stress, anxiety, depression, or any mental health issue? Majority of people, all 30 days was their answer. When asked what services they wanted, mental health services was often the answer, which is why you see it in that top 5 list. Whether they were, some people did share with us that they were already working with providers at Region 10 or in groups that were with Region 10, but we didn't really hear any kind of that traditional complaint of quality of care or continuity of care, except for youth. We heard that it was much harder for parents we were interviewing for them to get that kind of care for their children. And even, I'm thinking about one particular interview, even children who had just turned 18 living in rural localities, trying to find those connections. There weren't appointments available. There continued to not be appointments available. So certainly the appointment piece was the adult side of mental health that we heard, but not like the quality of care piece, I think, because they're just not getting in.
Right.
So I'll make that assumption. Yeah.
Thank you.
Thanks for the great questions.
I've got a question.
Sure.
You had mentioned that part of what you're working on towards the end is a tracking dashboard situation. So that sounds like a new element for this year's, this edition of the CHA.
Yes, this version 2.0 CHA, for this chip, we have heard way too many times that none of us are doing anything. And you hear this all the time too, because I sit in council meetings sometimes. And so everyone complains that we are not doing anything. And that could be true in a broad sense of the population, that if you surveyed anyone, that you would hear like, no, that you've never done that for me. So in an effort to be accountable and to actually follow through on these things and attempt to get them funded and measurably enacted, from other health districts out of state, we've seen they carry on dashboards, and they have a dashboard and they market that dashboard, and they keep all the targets and indicators and timelines updated on that dashboard and really message out, hey, y'all, this is what we're doing. Are you seeing it done? The other piece that we'd like to implement with that dashboard is return visits to some of the folks we've interviewed. So though all of these interviews are anonymous, some folks we've asked, would you like to be spoken to again in a couple years when we turn these faucets on of implementation and activities? And almost everyone has said yes. So we would ideally get back to folks and say, hey, I'd like to interview you again. What do you think? Are you seeing this happen? Is it easier to catch the bus? Are you microcatting it up, and get that feedback to follow up and then place that on the dashboard. You're right. It is a new thing for us to try.
Are there any other new things this go round that either you are doing differently or the conditions are different than they were in the past, or there's a policy that's new that you're excited about? I mean, you mentioned bike ped infrastructure. I didn't even pay her to say that.
I know.
But is there any how is the context different this go round?
Good call. Okay, context is different this go around from my last because last was still COVID heavy. So that really shifted a lot of the work from policy driving. How can we get policymakers to get involved and make shifts to peeling back much more to a very granular level. We hope someone will do activities in Fikeville for non-native speakers in bike ped. Like we are helping. The conditions are ripe for that kind of granular, focused work. And so that is probably a lot to do with the political environment in general and kind of what people have been going through from 2024 till now and watching kind of that political environment evolve. people want tangible results. And so we started there. So instead of saying, we're just going to work on chronic conditions, anyone can get a grant to do chronic conditions, you're done, we're really saying, please let it be granular. So I'd say that's different in that the quality of the terrain was different. And there seemed to be more, this time around, there's much more knowledge of collective action. So we've been talking about that, people go to MPH and we all talk about collective action, woo, and no one ever really can do it successfully because it takes an MOU and then it takes a grant and blah, blah, blah. People are working together very well right now, and our stakeholders are very much connected. So, for example, we've just stood up a collaboration of Nelson County providers to improve jaunt in Nelson County because we realized on a call, all of us were working on the same thing, and right there and then we stood up the group, and the next meeting happened, and they're moving. So I'm seeing more actualization of the work that needs to be done and less kind of academic discussion around it and much more movement. And that too may be the political environment. But certainly bike ped and transportation, though it didn't rank as high as, say, I need money, I think people are realizing that there can be change in that. And they've seen that in citywide microcat, they see trails being built. Again, it's that tangible result of the engagement. And so that might be helping the momentum.
Sure.
Does that answer your question?
Well, yeah, it's kind of like the dashboard is here's evidence of what we've been doing, a trail, a bike lane, that's evidence of what we've been doing, but then it helps people get to their appointments. It also helps them stay healthier in their daily life, and there's less pollution and all of that.
Exactly. I think we have a lot to tackle from getting folks from the health systems out back home, particularly rural. That's a huge problem. You two have heard me say this before, but at RTP, we have had cases, and we're not the only hospital, where people are readmitted to the hospital because they didn't get a ride for 24 hours after discharge. So they're just sitting in the lobby, not getting their medicine, not getting their care, because they can't get a ride. The Medicaid cab comes, it doesn't take them. So that's an extreme example, but it's enough to drive me personally to continue this kind of work, and I think it is what's also propelling a lot of no more. We cannot tolerate no action. We must act, even though we're a very big machine or at least system. There's got to be changes at the ground level that really start showing up and bubble up to that surface.
Thanks.
Anything else?
Just a broad question that I have for virtually everybody who comes in front of us these days. What are you thinking, or what are you most afraid of, or most realistically afraid of, coming out of the federal chaos?
Well, it's funny you say that because I wanted to include a slide from the Community Resilience Equity Estimates for you, because it would tell you your, at the census tract level, your life expectancy. That is not live anymore. So I can't pull that data because it has the word equity in it. So it was such an amazing dashboard. So fortunately, UVA has really stepped up and is sharing data with us, which is helpful. But I'm most worried not only that we are losing access to data, we're losing access to people. We are CDC supported with interns and other workers that have public health priorities, and they are now being furloughed and pulled from our ranks. So I'm worried that we'll be stripped down to a level where we can't actually do the broad, that I can't deliver. I'm a project manager. I need deliverables. I got to deliver. So if we can't deliver as health systems because we're connected to agencies that aren't going to let us vaccinate anymore, or it's not big moves, whatever the trend of not letting us do is, I worry that our community partners will also feel that pulling back, and that we just won't be able to do that work. Charlottesville's a tiny town. We all rely on donors and private funding to do a lot of this work, but if it's really crunch time and we're all asking the same people for those funds, the gap can't be swapped out.
Yeah.
Yeah, thank you for asking. Oh yeah, and Ryan.
Well, not necessarily specific to Map to Health, specific to the district as a whole. We are funded in part by 44 or 45 federal grants that work on things from HIV services to STI testing, WIC. And while we don't feel WIC is something that we would lose funding for, there's always that potential that other grants would be impacted. You mentioned that Jen is funded through a grant, which means it's not funded year to year on our local budget. And so a lot of that funding can come from federal dollars and federal grants that we in turn use for programming, people, delivering services. And so I think the mindset right now is thinking through what would be the worst case scenarios. What are the grants that we get? How do those fund mandated services? How do those fund services that we've identified are in need in our community? And then what's sort of the return on investment that we would be missing if those federal dollars weren't available anymore? And so that's something we're looking at internally. But then it goes to the people, like Jen said, where are we getting our information from? Where are we getting guidance from through the state at the CDC level or FDA or USDA, depending on where they are in the federal government. So these are all things that we're concerned with. And then how does that, and then in turn, impact delivery to those that need it, the end user, the community members who don't currently have access, even though we have those funds now, or who are seeking access for other services that aren't provided. So certainly an important question, something we're looking at, and I think it's very critical because as we're identifying what we need to focus on as far as the map, there's also these sort of areas that we need to address in terms of how do we meet these. We talk about showing what we're accomplishing, but how can we do that if we don't have the support we need, either through financial resources, staffing, or the funding to actually deliver those services.
Listen, thank you all very much. We really appreciate you coming out tonight. Anything else you feel like we need to know? Okay, listen, thanks so much for your work.
Can I say one quick thing?
Of course.
This is a point that I brought up in, I'm pretty sure it was RTP. Sometimes RTP and MPO blur in my head, but I'm pretty sure it was an RTP. And it ended up getting pretty easily misunderstood, so I want to try and say it clearly. This is not a knock on the county, for disclaimer there. A lot of the problem, when Jen made a presentation to us in that meeting, a lot of the, I think it was maybe about PATH, but a lot of the struggles that people who lived out in rural areas had about getting to medical appointments, or the isolation that you were describing, especially for young people. A lot of that is access related, and then you get down to the root cause of that. What is the nitty gritty actual reason why they are isolated? And most of it is affordable housing. They can't afford to live in the city and be close to their appointments and their activities and school and friends and all of that. And so there's of course people who choose to live a more rural life. These people are, the people who are struggling the most are not necessarily making that choice. That is the default option. Yeah. And so that's something we also need to keep in mind as we're discussing not just transportation, because you can only do public transit at scale so big. There's density, benefits that you just can't really cover everything everywhere. And so when we're thinking about the policy making position that we're in, it's also the most housing we can build near the things that people want to get to. That's important for bettering health outcomes as well.
Absolutely. Yeah, thank you.
All right, thank you all very much. Okay, now we're up with Deputy City Manager Ashley Reynolds Marshall. She's going to speak to us about the opioid abatement plan. Hello, Ashley.
Hello.
How are you?
I'm good.
Good.
Hello, friends. So today I have the privilege to speak to you all about the program for the Charlottesville City Opioid Abatement Funding. We're going to go through just a really brief history, just to level set everyone. I'm going to talk a little bit about the funding availability that we have, projects that have already gone through, and ones that have been proposed. All right. So also I do want to make sure everyone knows these slides will be posted on the Social Equity website, so they are a little wordy, only so that if individuals from the public just happen onto them, they don't have to watch this to be able to get the context. So I'm not going to read all these, but I wanted to level set a little bit.
Surely all the public is out there watching right now.
Absolutely, every single human. So, of course, we're talking about a public health emergency that began really in the 1990s. Everyone knows about OxyContin and the wonders that it provided, but also the detriment that occurred. We also have seen an influx of less expensive opioid alternatives. Most recently, you'll hear a lot of discussion of the drug fentanyl. What occurred really is that individuals were given these drugs most often, if it was a prescription pill, for reasons that were absolutely legitimate at first. They tore an ACL, they were a blue-collar worker that had an injury, and they became addicted to that particular prescription. When the prescription ran out, many individuals went to the illicit drug market to achieve the same results as best they could. This took a toll on communities, on cities, on states. And what we saw were states actually rising up and saying, "Dear pharmaceutical company, you knew exactly what you were doing. We are now suffering because we need to provide access to opportunities, to health and welfare, to our communities, so we're going to sue you." Virginia did just that. So all 133 subdivisions in the Commonwealth of Virginia agreed to sign on to one suit, and that does include us here in the city of Charlottesville. So the results of that legal action culminated in 2021 and 2022 with settlements from several large pharmaceutical companies as well as pharmacies. You see their names there. Some you probably know, some you maybe don't. So I wanted to ground us in just a little bit of data. I will tell people, if you happen to be a data wonk, at the back end of this presentation that will be published is a little more data, some from our good friends at BDH, some from our friends at the fire department, but I left the wonky stuff to the back. So here in the Commonwealth, there's been, in 2023 alone, 2,796 deaths due to drug overdoses. And 79% of those deaths, fentanyl was involved, fentanyl analogs, or the drug tramadol. There were over 20,000 emergency department visits due to drug overdoses in that same year. And over 30,000 of those incidents that were substance use related required EMS, which means here as local government, that is most often either a volunteer organization or our own city or county organization if you have EMS. Of course, here in the city of Charlottesville, we do have our own EMS service in addition to cars. So because of that, BDH and some other individuals did a really great work on determining the cost of this crisis. So in Virginia alone, the opioid crisis has cost upwards of $5 billion. And in the city of Charlottesville, each community member's per capita cost is over $600. So each and every one of us is supporting this crisis, which is another reason why, again, that lawsuit was so appropriate. So local data. I would like to publicly thank Lucas Lyons, who's one of our team members here at the Charlottesville Fire Department, for helping to supply this data on a monthly basis. And what I wanted to show you all is a little bit of the trends here in our community. So in 2022, there were on average 6.6, let's round up to 7 overdose incidents. An overdose incident is the fact that someone has overdosed on a drug and they call 911 to receive assistance. So do know that our overdoses may be higher than this. If an individual had a drug, if they had Narcan on them, they may have given it to a friend, or perhaps, depending on where they were at and how they were feeling, to themselves, and never called 911. In addition, oftentimes, someone may overdose, not know it, possibly survive, and it might actually have caused a death. But again, in 2022, we saw a spike in patients in August. In 2023, notice our average went up to about 8. And there you'll see in that graphic a lot of spikes in various months, with a high of 13 patients in January and 15 in July. And then in 2024, we actually had a reduction in overdose incidents to 6. There were sharp declines, as you can see, in March and then in October and December. However, we still had some spikes. So by no means are we seeing a lack of overdose incidents here in our community.
And when an overdose incident occurs, that means that there's been a call made
Correct.
to services, and then that person is taken to the hospital, or
It can
treated,
depend.
treated in situ or?
It can depend. Most often they are going to, even if they have successfully treated the individual on scene, they will take them to the emergency department just to ensure there's nothing else going on. But also there are some drugs where, for example, the Narcan dose will support alleviating an opioid, but there are some specific drugs that are that act as an opioid. We call one of them tranq. But Narcan will not resolve tranq. It will resolve if they had fentanyl in their system, for example, but you still need to be taken to the emergency department for any other drug or substance.
Okay, thank you.
Of course. So by the numbers, for gender, here in the city of Charlottesville, overwhelmingly, our individuals who are experiencing overdoses identify as male, with 70% of all overdose patients in Charlottesville identifying as male from all years looked at, so 2022 to 2024. We, of course, do have female patients that have been identified, but overwhelmingly this issue happens to be strongly leaning towards men. Yes, ma'am?
Do we know if those are, or if there are any repeats in that?
So this is not deduplicated data. So it is possible that an individual overdoses more than once within a calendar year. So what this looks at is it just gives me an overall dashboard, and a lot of that kind of more generic is to protect the patient data. So what I see, that little chart, is exactly what I get. Now that is something I absolutely can explore to the best of our abilities to see about that information. But generally, all of the data I've been able to receive is de-identified data, and often it is not deduplicated because that's very difficult to do.
Totally,
Yeah.
Thanks.
So by race, what we're seeing is that there's a prevalence of these medical incidents in residents who happen to identify as white, but you'll notice that there's an increase in usage of by African Americans starting really in 2023. You see a spike and then another spike in 2024. And we can equate that to the rise of fentanyl availability and usage in the population across the nation, including Charlottesville. This usage may have started on accident. Many other illicit drugs they were finding were being cut with fentanyl, thus then creating an additional demand for it. But also with the price of fentanyl, some individuals may have simply moved to that particular illicit substance at the time. But I did want to work to explain a little bit of that pretty sharp spike that just happens to come in 2023. And then by age. What you're going to see over the chart, if you pay attention to the graying, it gets darker the higher the percentage, is individuals are aging with their opioid use disorder. In 2022, while we did see a small percentage of incidents from age 10 to 19 and 70 to 79, most prevalent are 20 to 29 and 40 to 49. If you look at the next year, there's a 10% increase in age 30 to 39. Again, these individuals are aging with their substance use disorder. And then in 2024, you see again that 70 to 79 age group peak. One of the things that I will say colloquially that I received some information from our anchor team, specifically Pamela Coburn, who's a very valued member of our team, one of our mental health professionals, is they are seeing that there is a lot of difficulty for an individual to get into any recovery opportunities. And so when we think about that age, when we think about people aging, it could be, number one, that an individual is not ready to move into potential recovery, but it also could be that they've been ready multiple times and simply cannot get access to such treatment and care. All right, what everyone loves to talk about, money. So there are several streams of funding in the opioid ecosystem. Specifically for us as an independent city, there are 3 funding streams that we will talk about a lot. Direct distribution, that comes straight from what we call the distributors. So McKesson's, the Johnson & Johnson's, it comes straight from them to us. Independent opioid abatement funds and gold standard opioid abatement funds. I've got slides for those, so don't worry, I will talk about them in just a second. Additionally, there are city and county partnership funds. That requires working with other localities, and each locality can choose to add funds from their independent stream or not, and those projects have to be approved by the Opioid Abatement Authority in the state to receive funding. So this slide just simply shows the breakdown of the funding coming into the Commonwealth. You'll see that 15% of funding for the Opioid Abatement Authority can go to cities like us. And you'll see also that 30% of the funding is distributed straight to us. That's, again, that direct distribution. Funding is also available for state agencies through the authority, and there's some unrestricted funding they may use for other purposes yet to be determined. So again, that direct distribution comes straight to the city, straight to Ms. Gale in our finance department, who helps me out a lot with this work. And the city's projected distribution funding in all years, so that's 2022 to 2042, is over $1 million. What's important for me to share about this is that that money ebbs and flows. There are certain distributors that front-loaded their funding. They said, let's get it all out in the first 5 or 10 years. There are others that are giving funding throughout the entire time. So it is not an even amount of money that we're going to get every year, but it does change a little bit. But this is the amount of funding that, no questions asked, unless something happens, will come straight to the city.
And is that over 3 years then?
It's from
No.
2022
Oh,
through
20 years.
2042.
Sorry, I had mine.
Nope, you're all good.
2 and 4.
Yes.
So what is that? 50,000 a year?
But it depends. Because again, there are some distributors who front-loaded all of their funding, so we got more in. And then there are some that are trickling it out throughout the entire settlement time.
But that's $1 million annually, not total.
No, that's total.
Okay, total.
Yes, it's the projected funding from all years,
So it's
2022 through 2042.
Roughly 50, on average, 50,000 a year.
Yeah.
Which is not much.
Yes. And I do have, as I said, I tried to be a little less wonky. I do have a graph that shows the projected amount we'll get every year.
Cool.
So individual distributions. Remember I showed that graph that shows that the Opioid Abatement Authority in the state is getting in funding, and some of it they are holding for cities and counties that are not directly distributed to them, that 15%. That's made up of both individual and gold distributions. So the individual distribution, it's our money, but we have to apply for it. And if you don't apply for it, after 5 years, they will sweep it somewhere else. That funding is guaranteed so long as the project works on appropriate abatement. But there are some restrictions. Only cities and counties can apply for that funding. There is an amount earmarked for Charlottesville. And while they're not competitive, they are awarded 1 year at a time. So every year I'll have to reapply. So again, in all years, we're looking at about $365,000 is what will be available to the city of Charlottesville, 2022 through 2042. And then the final bucket of money for cities and counties is the gold standard funding. That required us to say we will use this funding in the way that it's intended, which is for opioid use disorder abatement and remediation. We have said that. That makes us eligible for an extra percentage of funding. You'll see that in all years again, that's about $91,000 and some change. We again have to apply for that funding because they have to make sure what we're asking for fits the requirements.
Do we have to apply every year?
Yep, every year I get to send in a renewal application.
Okay.
Yeah. Mainly they want to know it's for reporting purposes, so I'll have to report back data as well as to make sure we're still using the money in the way we said.
I hope it's not too much of a
It's not terrible.
Okay.
All right, so again, I've talked about what's allowed. What's allowed? You can spend money to treat opioid use disorder, which you also will see in documents as just OUD. You can spend money to prevent opioid use disorder, and you can spend money to abate or remediate opioid use disorder. That's it. That's the only thing this funding is intended to go to. What can't you spend it on? I can't supplant. So even if we had already been working with our good friends at the health department on a fantastic program, I can't use any of this money to now cover that program. If they add a new element, I can, but if it's the same program, can't do that. I can't use untested methods. In those application processes, they're going to look to see, and they actually ask, and you give them the data, that the projects are evidence-based or evidence-informed. So someone can have a fantastic idea, but if I can't find a good journal article on it, I can't apply to the Opioid Abatement Authority to use the money. And even though we have direct distribution, remember, to get that gold standard money, I pledge we will use all of our money to the highest standard.
So, I'm sorry, some localities can say, we're going to use it for the police department or whatever, like what?
So there is actually guidance now as to what you can and can't spend on law enforcement. And you'll see across other states that maybe have different requirements from their state that, yes, people have absolutely used them to purchase vehicles, for example, for the police department. In the Commonwealth of Virginia, they have set up standards through the state where that most likely is not an allowable use. I say most likely because it depends on why we're asking. I can make a phone call. But we're really looking to spend this money to remediate and prevent opioid use disorder, or looking at education as well. So it is very hard to use that money in this state for other purposes, but that's a pretty famous usage that somewhere, I believe in West Virginia, got a lot of press, not the kind they wanted, about. So in brief, 20 years of the program in full. We have about $1.5 million of funds total projected to come to this community. We've expended $45,000 of it at this point. We are a part of 2 cooperative grants, and we have 3 grants in review. So the approved projects, we, along with our partners in Albemarle, Fluvanna, Greene, and Louisa, worked with Region 10 for expansion of the Crisis Response Assessment Center. They call it a CTAC. The CTAC is where an individual who is in crisis but is willing to voluntarily go to receive an evaluation can go and comfortably receive that mental health evaluation in a place that's not an emergency department. For that particular program, the City of Charlottesville has not pledged any of its own money, and the funding to do this work came straight from that cooperative bucket that I showed you from the OAA. We also participated in, with the same partners, in expanding the Blue Ridge Center community outreach work. So that's working in community outreach, working to connect individuals to services who have or are at risk of developing opioid use disorder. Again, that funding is from the state. We have not provided any of our own funding for this particular program at this time.
So that means that there was $609,000 awarded from all of those listed below.
From the state. So that's why Virginia OAA funding, it's from the state only. We have not given any funding for this program, but there was that bucket in the chart. Let me see if I can go back to it just because it's a little easier. There we go. There's that 35% that is city and county partnerships out of the opioid abatement percentage. That's what we're applying for when we talk about a cooperative grant. Now, you can put some of your own money in. They like it when you do, but we got those 2 in first year.
Right, but that's not that 600 and whatever thousand. That's not made up of our contribution from the 1.053 million.
Correct.
That's a different.
Yes, it's that
fund. Special
special 35 bucket that's in gold on the side
Okay.
that we can't touch unless you apply for it and they grant it.
And the 1.53 is which of these? And on the pie chart, which color is that?
Sorry, I will go back if I remember to hit the right button. So our direct share is the 30%. So that's the million over the 20 years that I showed that comes straight from Johnson & Johnson.
The blue pie wedge.
Yes.
Got it.
The funding where I called it either individual or gold standard, that's that little 15%. I see it as peach, but in the sidebar.
A light strawberry.
Yes, I like that one better, a light strawberry. So that's where that funding comes from. So we
Okay.
get funding straight from the distributors. We get funding that we submit an application for from the Opioid Abatement Authority, and then we can do collaborative work that's a different bucket of money.
So this might be later in your presentation, the 45,000 that we've already spent.
Yep, I'm getting to it.
Okay,
It's
thanks.
the next slide after I make it back.
Okay, thanks. I'm just trying to figure
Nope.
out how what all corresponds to what here.
Yep, nope, and that's why I wrote much more on the slides. If you have to go back, you've got a lot more context,
Thank you.
of course. trying to switch slowly so that I don't. All right. So we've talked about 2 out of 3 cooperative grants. Here's the third. The third cooperative grant works with partners in Albemarle, Fluvanna, Madison, Nelson, and Orange to expand the specialty docket, which is our drug court. For this one, we are giving our support as the fiscal agent for this project. So we receive the money, we help OAR distribute the money, we work as their fiscal agent for drug court already, so we were able to take on these expanded duties. We did not provide any funding from the city for this because the expansion really is going to support our counties, but we wanted to play in the sandbox, so we did volunteer as being the fiscal agent. In this project, some of the counties did give their own individual money or direct money, their choice to do so. But for us here, we are serving as the fiscal agent and we still have not expended any of our money. And again, because it's really expanding into our surrounding counties, our drug court is doing really, really well. We're very proud of it. And finally, sorry about that little squishiness, but here's the 45. Council approved in February of 2024 to distribute funding to the Charlottesville Fire Department for their naloxone vending machines. It is a requirement because it is still considered a prescription drug that they had a method of being able to account for any of the Narcan that they were taking out, as well as be able to report on the supply. And so council approved us using some of our direct distribution for that work. So right now, this is all we've spent, is that $45,073. However, as I noted, we do have some applications that are in review right now that I'm very excited to talk about. So one of the applications that we have submitted in partnership with our friends in Albemarle and Nelson County and the regional jail is to do a pilot where for 18 months we're going to try and introduce Sublocade, which is a 30-day injectable form of buprenorphine. Sorry, still Southern. And what that does is, our hope is that it will allow that vulnerable population of those who are justice involved to be able to have some steadiness during their incarceration period, because unlike a daily buprenorphine, it lasts 30 days. In addition, there also is a high possibility of that individual being released with several days, if not weeks, of treatment under their belt. So they're not leaving immediately, either A, wondering how to find treatment for their substance use disorder or opioid use disorder, or B, potentially relapsing into using because it is difficult to find that treatment. This application does suggest that we use 3 funding sources: direct, individual, and gold. It will last 3 years, and again, all of the partners in the jail are participating together for this trial.
Is this something that other localities have done successfully?
Yes, this is actually a very successful model that we've seen. ACRJ has recently just dipped their toes into providing opioid use disorder treatment through oral buprenorphine, but they have never before had a really formal program, so they're very excited to have it. And one of the things that really helps us have that is the ability now of the jail to have not contracted nursing staff that may rotate, but having in-house nursing staff and mental health professionals to be able to not only provide this medication and this opportunity, but to be able to monitor the individuals who are receiving this treatment in a really good way. I'm really excited to see how this turns out for our particular community members and the potential, again, success that they can have upon reentering as our neighbors and friends here in the community with this bit of sobriety, given that I mentioned earlier, it's very hard for people to find treatment. And then another project that we are proposing right now, it is actually in review, is an embedded mental health clinician at our emergency communication center. Again, working with partners in Albemarle County, because it is the Charlottesville University Albemarle County, ECC. We have proposed, again, another pilot to see what it will be like to have a mental health trained individual be able to take calls as they come in. so that there is a potential that we would not have to dispatch a law enforcement officer if the individual can have enough counsel maybe to feel like they could report to the emergency department, or a family member or friend can take them. They're again having that ability. We also are hoping to reduce some emergency room visits. We're modeling this after Durham, North Carolina's HEARTS program, their co-responder program that also includes peer response and this emergency communication clinician. For the city of Charlottesville, we are seeking to pay for that using, again, a combination of direct, individual, and gold funding. And our partner in Albemarle County is also asking for not only OAA funding, but they received a BJA grant that will help provide some of the funding for this pilot. And then the third application is citywide Narcan access. If you go out to our AEDs right now, there's no Narcan dose. We're going to fix that. So using, again, a combination of direct, individual, and gold funding, we will look to make sure that all 65 bloodborne pathogens boxes, which coincide with our AEDs, will have 4 doses of nasal spray naloxone in them, as well as we'll be providing doses to front-facing locations in key city properties, and providing Revive training for those individuals, thanks to another one of our members of our anchor team, Mr. Norman Denise, who can lead those trainings, and actually I can too. So we're very excited about that. If any of you all, once we're able, would like to get Revive trained, it's super easy, and we'd love to train you as well, but we're collaborating with risk management on this. Some potential future projects, both UVA and Region 10 have funding for what we call harm reduction vending machines. Those are vending machines where there may be Narcan or other doses. I do want to give a shout out to Councilmember Snook for presenting me with these machines like 2 years ago, I think. They are finally coming, hopefully, to fruition in the community. Richmond just launched 3 themselves, so we are looking forward to both partnering with those agencies as well as making a determination if we also maybe need to add to that availability. Knowing that Richmond was able to launch 3 with opioid fund dollars gives me a lot of confidence. If we'd like to use some of our OAA funding for that, we'll be able to. Also working with Pamela Coburn and Anchor, we've looked at the issue again of treatment. They have some incredibly sad stories of individuals who they responded to their crisis. The individual really wanted to get into treatment and something happened. They couldn't get there. The treatment facility couldn't take them that day. And so they see a need for a navigator. If you think about going into recovery, even if you've just had surgery, it'd be really hard to do a lot of complex paperwork sometimes, for example, things you maybe aren't familiar with, but that's what we expect individuals to do who need to go to recovery. Fill out all this paperwork, show up on these days, have all this availability. They maybe don't have that bandwidth. So I'm working with Pamela to talk over the possibility of maybe a pilot for a substance use, opioid use disorder treatment navigator in our community to see if that would give additional support to people who are seeking opportunities for treatment. And then also working with Tamika Braveheart at UVA on a concept that she shared. She happens to speak Spanish and was at one of our local food trucks, and people knew what she did at UVA. And they said, hey, do you happen to have Narcan? We would love to have a dose of Narcan to be able to save someone if they need it. And so we're wondering, are there more businesses like that that are willing to be helpers, that maybe would like to be Narcan trained and would like to be able to educate their communities and have those doses more place-based? So Tamika and I are talking a little bit about how maybe we can make that happen, and that certainly would be something we could use opioid dollars for. So that's it. Please let me know if you have any questions. As I said, the next slide behind this is really wonky data, but it will be available for your heart's desire. But happy to answer any questions or concerns you all may have.
So Lord, I'll start with you, sir.
I don't have any questions, thank you.
Yeah.
Thank you, Ashley.
Michael? No.
I already bugged you with a bunch of questions.
Yeah.
Thank you.
Good.
So
I do, let me ask you the same question I asked the other folks. What's the great fear that you're concerned about it coming out of the federal chaos?
For us, I think the first thing to note is that the opioid abatement funding is protected. It is coming from those for-profit distributors. The one that is in flux is Purdue, as they have filed for bankruptcy, so that's the worst thing that could happen with those funding, but none of it is federal funding, so that's a positive. However, our partners may be federal funded. For the ECC grant, that is federal funding that our friends at Albemarle County pulled down. And so those are all concerns, especially when we think about access to care and treatment. We not only need access to, of course, opioid use disorder treatment, but general medical care, as Jen was talking about. Many times it's a toothache or another ache or pain that may drive someone to a point of looking at an illegal substance to resolve some of those issues. But if we can get them into quality health care, maybe we can head off some of that before it starts. But if our free clinics and federally qualified healthcare centers funding is in jeopardy, if Medicaid funding or Medicare funding is in jeopardy, for example, or any of those surrounding benefits supports, that can put someone in a peril either to relapse, to start using an illegal substance, or to not be able to provide the support that they maybe would to a loved one.
Thank you.
So when I was coming in, you were talking about a term I hadn't heard before, trank or?
Yes. It is a animal tranquilizer, and we know that someone may be using it because it causes necrosis of the skin, so it will eat away near the injection site. From a public health perspective, we still would encourage individuals, if they believe a person is overdosing on anything that could be an opioid and they have access to Narcan, to give that dose. Narcan, if I gave you a dose or myself a dose right now, we will still be standing and talking to each other even though neither one of us needs it, which is one of the beautiful parts of that particular drug. However, if someone who is providing supportive care notices that there's a little bit of necrosis on the skin, we tell you all the time to please still call 911, even if you give a dose of Narcan. But in that case, the Narcan will not be effective. And I have not necessarily heard of any changes in that formula that would make that effective. But that was just an example I had in my head of a drug where, again, it will look like a traditional overdose often that may be equated to opioid use disorder, but the person may not revive once you give them the dose of Narcan.
So is this a new, because wasn't it something else that they used to tranquilize horses or something that people were using?
There's sort of always something
Okay.
new,
Yeah.
but
This is something.
But begging a glance to my friends, I feel like I started hearing about Trank from Virginia Level maybe 2 years ago.
Yeah, I was going to say Jen is my connection to that, and I would agree with that.
Yeah.
And it's usually used to cut fentanyl, correct? It's not on its own primarily?
It depends. In the same way where we've seen fentanyl move from something that individuals cut other illicit drugs with to now being a drug of choice for some individuals, you'll see the same thing with Trank.
Something else, wow. So, any other questions or comments, Sam? Is there anything for us to do? Is this?
No, I would say for me, this is an opportunity for council and public to be briefed on the fact that we are receiving these funds from the state, and that we then operationalize them by putting them out on the street to intervene where possible. I always look to see if there's anything that you hear that you'd like to see us do more of, that you have questions about. And if you feel confident that the information as presented is good, we'll keep going.
How would we get the training that you mentioned?
Just let me know, and I will make sure that we can set a good time. Maybe I'll look in the future to see where maybe you don't have a closed session or a shorter closed session. It's not a long training, and we'll be able to get you that training. That is what I love to see. Dose of Narcan in the bag. Love that.
I keep in my scooter.
I love both of those things because really that's one of the beautiful things about Narcan is any one of us can help save a life. And again, it's not, if you give CPR, you have to be prepared for what you have to do, and other things. This one, it is very easy, it is very simple, and it literally can give someone a new lease on life by carrying that tiny little package with you if possible. But also we're going to do things where we'll make it available so we could run right out of council chambers and be able to access a dose.
Yeah, thank you.
Thank you so much.
Thank you.
Thank you all for coming
Yep.
as well. Thank you. So we're going into closed session now?
Yes. Pursuant to Section 2.2-3712 of the Virginia Code, I move that the City Council close this open meeting and convene in a closed session as authorized by the Virginia Freedom of Information Act as follows. Under Virginia Code Section 2.2-3711A1 for discussion and consideration of prospective candidates to be interviewed or considered for the following boards and commissions: Charlottesville Economic Development Authority, the Human Rights Commission, Police Civilian Oversight Board, and the Tree Commission.
Second.
Okay, can we vote? Okay, we're in closed session. We'll be back at 6:30.